Thanks, Jeremy, and thank you to everyone. And yes, Jeremy, I left Joburg and I'm now in Cape Town, but I still actually love Joburg. Don't tell my wife, but alas. So thank you everyone for attending this talk. And I will be talking about, as Jeremy has alluded to, basically preventing hospital-acquired infections, because this is quite a big problem in hospitals, and something that I found is quite neglected in our training, in both in undergraduate and in postgrad. So yeah, let's get going. So essentially, I'm going to be looking at these elements over here, and firstly, at the top, you're going to have your hand hygiene, then surgical site infections, your peripheral line associated bloodstream infections, and then your central line associated bloodstream infections, and then catheter-associated UTIs, ventilator-associated events. It's changed its name. And then we're going to be looking a little bit about chlorhexidine washing, as well as decolonization of patients. And then obviously we're going to look at antimicrobial stewardship, because this is one of the foremost areas that is as low-hanging fruit that is we are able to prevent hospital-acquired infections. Okay, so why do we care? I really like this infographic from the World Health Organization, and here it says 1 in 10 patients receiving care will develop a hospital-acquired infection, and I'll show you some data supporting that. And the scary thought is up to 90% of healthcare workers do not clean their hands in some facilities. And I'm sure when we have been to colleagues or we working on patients, that we don't always wash our hands, including me. It's something we forget. And it's a real big problem with regards to hospital-acquired infections. Now, this was a nice systematic review, which was in 2022, and looked at healthcare infections associated in Africa. And as you can see, the pooled prevalence was around 12.8%. But if you compare us to the rest of the world, Asia sits at around 9%, Europe 6.5%, and in the USA, they're only sitting at 4%. And in actual fact, the US is quite an interesting area, because some of the hospitals will actually penalize the hospitals if patients develop, for example, C. difficile infections. And we don't have that in South Africa, and I'm not sure it will work, because I'm not sure who will be paying for that. But anyway, so what was quite interesting is, from this article, is what are the hospital-associated infections that are big problems? And in every hospital, it's surgical site infections that sit at around 42%, and bloodstream infections 17%, pneumonia 17%. And I found this quite interesting, because I didn't expect some of these results. And as we know, recent hospitalization is a big risk factor for the development of HAIs at an adjusted odds ratio of 4.17. Peripheral venous catheters, so that's the drips we insert as healthcare workers, which is sitting at 2.87. And surprisingly, diabetes is a big risk factor for the development of HIs, which I wasn't really aware of. I mean, it's something we always keep in the back of our minds, but to be such a big risk factor, it's quite surprising. Okay, so let's go into the most important way of preventing infections in hospitals, and that is hand hygiene. So when should you be doing hand hygiene? So the World Health Organization has been a big proponent of this, to ensure that us healthcare workers are doing hand hygiene in correctly, and also in the correct circumstances. And as you can see, there are 5 moments. So before touching a patient, before clean or aseptic procedure, after body fluid exposure, after touching a patient, and then after touching the patient's surroundings. And that includes the cardiac table of the patient. And what I mean by that is, that's the table where we put notes on, where the patient's food goes on, etc., etc. And we've been doing hand hygiene audits in our hospital. And one of the interesting aspects that we have seen is that the moment that is most commonly done by healthcare workers is actually moment 4. And that begs the question is, why are we doing hand hygiene most commonly after touching the patient? And I think that might be related to us as healthcare workers not wanting to get the infection from the patient. And in actual fact, we should really be pushing number one as a big proponent of hand hygiene. All right, so how do you do hand rub? So hand rub versus hand wash. All right, we'll go into a video on the next slide, which will explain how to do it. But I always get this question is, when should you be doing hand rub with alcohol-based sanitizers, or when should you be washing your hands with soap? And I always say to people that if your hands are visibly soiled or feel soiled, then go wash your hands with soap and water. And when should you be doing hand rub? Well, you should be doing that every other occasion. And I actually prefer hand rub because I think it is more an efficient means of hand hygiene. And if I think about the circumstances we have in our hospital, in our general wards, we have 1 tap per 6 patients, but we should be having 6 alcohol-based hand rubs between every single patient at their bedside. And from an efficiency point of view, especially in general medicine, where you're seeing a large amount of patients, you're not going to go up and down to go wash your hands between the patients. And in actual fact, the best way to do it is to do alcohol-based hand rub. It's more efficient. It's right next to the patient's bedside, and it's quicker. So this is the video I'm going to show you. I hope it works and you can hear the sound. I'm going to be showing you how to use alcohol-based hand rub and to do hand hygiene in the clinical area. So put about 3 ml of alcohol-based hand rub onto your hands, and then start with your fingertips like this, both sides, rub your palms together, rub your fingers together, and then don't forget your thumbs, and then interlock your fingers like this as well, and then just keep rubbing for around 15 to 30 seconds to allow the alcohol to dry, and then you are good to go. Thank you. So just to comment on this, I remember when I started my ID training, Professor Mark Mendelson came to me on my first day and he's like, "Tari, do you know how to wash your hands properly?" And I was like, "Yes, Mark, of course I know how to wash my hands properly." And in actual fact, if I look back, I had absolutely no idea of how to do the procedure properly. So I think it's something that as clinicians, we all think we know how to do well, but when you actually need to do all the steps, there's more to it. Okay. And now this is also quite interesting. Many years ago, they used to say that one needed to do at least 1 minute of hand wash or hand rub to ensure that your hands are clean. And these 2 studies, one done in a neonatal ICU and one a prospective randomized crossover study, showed that in actual fact, 15 to 30 seconds is sufficient to wash to do alcohol-based hand rub or hand washing. All right, and this is one of my favorite slides when it comes to looking at hand hygiene compliance. It's a systematic review which was done in 2022. And the objective of this systematic review was to assess hand hygiene compliance and see the relationship to hospital-acquired infection incidence. Now, one of the limitations to this systematic review is that in the studies that they looked into, many of them actually, the secondary outcome rather than their primary outcome was looking at hospital-acquired infections. And another problem is many of these studies took place in high-income settings. So they evaluated 111 studies in the systematic review, of which 50 showed a hand hygiene compliance of less than 60%, 43 showing hand hygiene of 60 to 80, and 18 showed a hand hygiene compliance of more than 80%. And what you can see from this figure over here is that about 60 to 70% hand hygiene compliance will decrease your hand hygiene, your hospital-acquired infection incidence. And what I find quite interesting is that there's a number of studies which showed 100% compliance. And I find that quite hard to believe. And yes, there are some areas that have 100% hand hygiene compliance. And if I think about what we have done at Groote Schuur Hospital. Our infectious ICU unit was around 100% compliance, but every other ward was not 100%. And I think even in the best centers in the world, and one of the best centers in the world is Geneva Hospital, where Prof. Didier Pate works. And I was reading an article from them recently, and their hand hygiene compliance sits at around 74%. So trying to get 100%, I think, is quite difficult. But it is something that we should all strive towards. And especially now looking at this data, if we can get to 60 to 70% hand hygiene compliance, we'll start to decrease hospital-acquired or hospital-associated infections significantly. Okay, let's go on to the next big topic, which is your surgical site infections. And this is a way of approaching the prevention of surgical site infections, looking at from a preoperative, intraoperative, and post-operative state. And cleaning is one of them. So there's been some literature to support before your patient goes for operation, they should ideally go and have a bath or a shower with chlorhexidine. If not, then at least soap and water, decreasing the microbial load on their skin. And then importantly, nutritional support for these patients and screening for MRSA. There's high level evidence for that. And that has been done in the orthopedic as well as in the cardiothoracic units. In saying that, from our Groote Schuur data, we have less than 5% of our cases are MRSA. So if you are going to do an intervention and screen everyone for MRSA, I think it's quite expensive. And especially for patients that are coming from the community, I don't think in our setting this is relevant. But obviously in settings where community-acquired MRSA is a problem, this is definitely one area to look at. Hair removal, I'm sure most people know that we shouldn't be using razors, but rather clippers, and that's related to the microabrasions that you can get. Now, immunosuppressants is an interesting field in the sense of more and more people are going on biologics, and what should you be doing for these patients that need elective surgery? And for those patients, ideally, you should stop 2 half-lives of the drug before attempting an elective surgery. If you need to give steroids, there is some data suggesting that, yes, there is increased incidence of surgical site infections, but then at the same time, there's data saying there isn't an increased risk. So steroids don't seem to be the worst. And then oral and IV antibiotics for colorectal surgery, that's got high level evidence. And then going into your intraoperative, so ensuring that patients are cleaned with alcohol-based antiseptics, so combining with chlorhexidine. And interestingly, a few weeks ago, there was a study which came out in the NEJM in orthopedic fractures, and specifically closed fractures, where they showed that iodine is superior to chlorhexidine alcohol combination. But in general, we see that alcohol plus chlorhexidine is the way to go. Antibiotic prophylaxis, yes. Normothermia, glucose control, as we just alluded to in the first few slides, diabetes is a big problem. Once again, hand hygiene before operations, ensuring you got sterile gloves, ensuring there's good operating room ventilation, and then ensuring there's a bundle of care. So what that means is a patient that enters into the operating room is you have a colleague there that ticks, has the patient been cleaned? Yes. Is the urinary catheter in situ? Yes. Has the patient been given antibiotic prophylaxis, etc., etc.? And then post-operatively, as we all know, glucose control becomes even more important, ensuring that the dressings are kept nice and clean, and then stop unnecessary antibiotic prophylaxis. And there are going to be studies that are going to be looking at this and commenting on the duration of antibiotic prophylaxis. So watch this space. Okay, to move on to the next section, which is your peripheral line-associated bloodstream infections and your CLABSIs, central line-associated bloodstream infections, something quite close to my heart. And CLABSIs. So what is a CLABSI? It's essentially a bacteremia that is associated with a drip that is inserted in a patient. And as we always say, you need to look for other sources of a bacteremia before you can call it a plabsy. But in many cases, one will note that the patient has underlying erythema, maybe even some pus draining from the insertion site, and then you grow the organism. Now, a CLABSI is essentially the same as a plabsy, but it's obviously a central line. And there is things that can assist you with trying to understand if a patient has a CLABSI versus a primary bacteremia. And that looks at the differential time to positivity. And what I mean by that is looking at how the growth of the organism occurs. And generally, if it's a central line infection, that will grow within 2 hours. And if it's a bacteremia, it will usually grow 2 hours afterwards. So to explain that slightly differently, if the lab calls you at 9 o'clock and they say your CVP culture is positive, and then they call you at 11:30 and say, now the peripheral one is positive, then that suggests that it's more likely a central line associated bloodstream infection. But on the other circumstance, they call you at 9 o'clock and they say, CVP blood culture is positive and your peripheral is positive within 2 hours of that. So, for example, at 10:30, then that suggests that it could be potentially a primary bacteremia. And importantly, when we have these central lines, people sometimes forget that you need to take multiple cultures from the line. So what I mean by that is if you've got 3 lines, 3 ports rather from that one central line, then you need to take 3 blood cultures from there as well as 1 peripheral. So potentially 4 blood cultures on a patient. Okay, why do we care about plabsies? And this is quite interesting that 330 million peripheral catheters, so drips, are sold in each year in the USA. And 30 to 80% of patients admitted will have a peripheral venous catheter. And anecdotally, from working at Groote Schuur, many of our patients that are admitted, when you see them in the emergency department, they get a drip immediately and blood's taken at the same time so that you can save time. So when you see that the bloods are abnormal, you can act on that rather than pricking the patient twice. Now, the problem is the mortality of a plabsy is not insignificant at 12.6%, and I'll show you some data on the next slide showing it's actually higher. And the cost of a plabsy, yes, this is data from the Europeans, and with exchange rate, it's overinflated, but it's around 240,000 Rand per bloodstream infection. So very high costs towards the hospital, and obviously the morbidity which is associated to the patient as well. Okay, now this is something I wanted to include in the slide because it was a study that was done in Ireland, and they showed that 38% of drips that are inserted are unnecessary. And I think as clinicians, we forget to sometimes tell our patients why drips are inserted. And in the study, they showed that patients who do not know why they had a drip were more likely to develop bloodstream infections. And further to this, this was a study which was done in Spain and looking at 14 internal medicine departments. And they showed 25% of patients that developed a plabsy no longer actually needed a drip at that time. So again, are we checking our drips often enough to ensure that patients don't need them? And this was a study which was done in 2017 at Groote Schuur Hospital. And they were looking at some of the epidemiological aspects of Staph aureus bacteremias. And they showed that from plabsies, you're sitting at around 57% of patients develop a MRSA bloodstream infection because of a drip that is inserted. And the central line sitting at around 16%. And the inpatient mortality was 42% with a 90-day mortality of 47%. And the study was repeated a few years later, and of note, because of infectious diseases being involved in every Staph aureus patient, the mortality went from 42 to 16%, which again puts us in happy places because that means that we are important people for our patients. Okay, so now I'm going to shift things a little bit and describe what can be done to make a peripheral venous catheter bundle. And that means creating a trolley. I'll show you some photos, looking at Welsh crosses, giving feedback mechanisms, and having your checklists in the hospital. So this is a very practical approach to what can be done in your facilities. And before we did that, we made sure that we taught people how to put in a drip. And I always say to people, I only learned how to put up a drip in 2021. And I'd already been a clinician for 11 years, not including all my training that I did as an undergraduate. And it's something that I don't think we get taught well enough in an undergraduate level, but which is actually increasing now with time that has moved on. And this is what the trolleys used to look like. This is pre-COVID. The whole hospital tried to put trolleys together to help with insertion of drips, and as you can see, they're quite messy. I mean, yang cowers for suctioning, urinary catheters, Colt's needles, etc., etc. And what happened subsequently is we put together a peripheral venous catheter trolley, which looked like this, and it was neatly packed and had all the consumables you need. And at the bottom, you would have your skin prep antiseptics, your sterile packs, your sterile gloves. And this helped clinicians to be more efficient. And I remember I did my internship in community service and medical officer time at Helen Joseph, and I absolutely loved it. But it did get very frustrating at times when you couldn't find equipment. And I used to walk around with a toolbox with all the equipment inside to make me more efficient. And I think this helps clinicians now to have things in one place for them. Okay, and then giving feedback to clinicians. So there's no point in telling people what to do if they don't understand what they're doing it for. And when we started this in November of 2022, our correctly placed strips were only sitting at 32%, and then we went all the way until now at about 86%. And as you can see, our phlebitis has also come down, probably not significant numbers, but one thing you need to remember is you need to give feedback to clinicians to know why things are important, showing them the evidence behind PLABSIs, etc. And this is just some examples of drips that were inserted in incorrect areas. And I can promise you, if anyone has seen patients today, they have definitely seen this. So this is the white label, which is placed over the top. There's blood underneath. And in actual fact, this white label should be on the side, because if you look closely next time at this op site, at the transparent dressing, it's actually got a date area. So it shows you the date that the drips should be inserted. This is another one of my favorites. And underneath here is actually the patient's sticker, hoping to hold down this drip. And this is my very favorite because this is the patient's hand and this is the patient's elbow. So the drip is going in the wrong direction. The person hasn't taken off the white paper label around the side, and they left web core inside over there. And this is just a nidus for infection. As we all know, Staphylococcus aureus has got an enzyme called hemolysin, which loves blood, and there's a perfect media for it to grow. And then this is what a drip should look like. This is not 100%, but it's pretty good in my opinion. Ideally, we should be having a label as well. And what you can see is there's nothing covering the front over here. So if there's any surgical sites, if there's any phlebitis developing, you'll be able to see it early. And also this area is not going over there, the tubing over here. And I know it's not in an ideal circumstance, and you might argue that the bacteria, etc., can go underneath the tegaderm over here, but I think it's pretty okay. Okay, and then this is what we call a Welsh cross. So again, it's a feedback mechanism to clinicians and the nurses in the ward, and basically it shows the days of the month. So 31 days, green is good, red is bad, and red means that there's been bloodstream infections related to PLABSI. So on the 3rd of, for example, June, the 12th of June, there was two plapsies in this ward. And then if the wards had no plapsies, then we put them a smiley face. And this is in every ward where patients are seen and where clinicians can see them. And then another area which is part of the nursing progress with admission to patients is having a daily peripheral line check list. And this is essentially very similar to what is done with the CLABC data and the best care always. And it's basically something that we put together, replicating what we've seen from them. And it basically ensures that healthcare workers go and check the drips on a daily basis and ensure that there's no erythema, no phlebitis, etc., etc. Okay, so now I've said to you what is the method that can be used for a bundle, and one of them, and now we need to look at, well, what is the evidence behind these bundles? And this was a systematic review in 2019. It looked at 13 studies, of which 12 studies showed that there was a reduction in phlebitis as well as plapsies. One study showed there was no difference in the plapsy, but in actual fact, there was an increase in phlebitis. And what's quite nice to know is that 7 studies showed a reduction of between 19 and 81% in bloodstream infections. And of note, there are many different bundles, but in some of these studies, the amount of interventions was only between 2 and 7. In saying that, I know the evidence is not fantastic, it's low to fair. Okay, let's move on to the next section. This is catheter-associated UTIs. So what is a catheter-associated UTI? And essentially it's a bladder that has been catheterized or has been catheterized in the last 48 hours, and a patient develops a urinary tract infection. And now, how do you prevent it? So there are a number of aspects, okay? So firstly, avoid the unnecessary insertion of urinary catheters. And I know my renal colleagues may get upset with me, but for example, if you have a patient that's got renal failure, could you rather attempt to use a condom catheter or Paul's tubing instead of using a transurethral? And if the patient is awake and alert, can you ask them to rather pee in a bottle rather than having something invasive? Inserting the urinary catheter in a sterile manner, reviewing each day the need for the catheter, maintaining care of the urinary catheter. Now, this is a big problem. And if I show you over here, I was very proud of the one ward I went past where the urinary catheter is now on a stand, preventing the area from lying on the floor, because I'm sure many of us have seen urinary catheters lying on the floor. And the problem is the bacteria just crawl up here and then crawl along the pipe and then go down into the urethra, and the patient gets an infection. So please lift your urinary catheters off the floor. Now, another thing is timing of change. I remember when I was intern, we used to routinely replace catheters on patients every 4 weeks. And the literature says that in actual fact, you should change them when there's obstruction or when the patient develops an infection. There's no dedicated time for replacing them. Coating is a controversial area. Some studies have shown silver is good. Some have said it doesn't make any difference. And then again, when I was an intern, I always remember being taught that patients that need a catheter for a prolonged period of time, ideally you should be placing silicone catheters. And from an infection point of view, but in actual fact, that's not true. You don't need to. Latex or silicone, it's the same risk of infections. Obviously, your patient that's allergic to latex, you're rather going to choose a silicone-based catheter. And then what about using this nitrofuranone impregnated, which inhibits DNA synthesis of the bacteria, and that has been shown to be effective in some cases. But one of the problems is it's carcinogenic, so let's not go down that route. And then vaccination. So a very interesting field. What about vaccinating your patients against E. coli? What about vaccinating them against Enterococcus? I think somewhere to look into in the near future. And then bacteriophages is another area of interest, looking at prevention. And then let's move on to ventilator-associated events. Now, this is quite a complex slide, looking at it, and we'll get onto something easier to understand and easier to remember. But essentially, ventilator-associated event, ventilator-associated condition, and then infection-related ventilator-associated condition. And is it a possible? Is it a probable? It all gets a little bit confusing. But from what you can see over here is that it's a patient that's been stable on a vent for 2 days, and then for 2 days, they have an increase in their FiO2, they have an increase in their PEEP, and at what are the temperatures, what is the leukocyte count, is there microbiological confirmation, et cetera, et cetera. So complex, but a nice way, simplified way of seeing it is a patient that has been on the ventilator for more than 48 hours or was extubated in the last 48 hours, who has got clinical, radiological, and microbiological changes in keeping with a ventilator-associated event. And in our ICU, they do surveillance tracheal aspirates on our patients. And I do not like surveillance cultures in general, but I think in an ICU setting, there is some literature to support it. And what that means is, for example, if they do a surveillance culture on Monday and it comes back as a Klebsiella pneumonia on the sputum, but the patient is absolutely fine, and then by Wednesday you start noticing the patient's going off and you're worried that there's a ventilator-associated event, then what you can do with knowing that there was a Klebsiella is that you target your treatment to the Klebsiella. But before doing that, you're obviously going to send off blood cultures and tracheal aspirates, et cetera, et cetera. So it does have some utility in doing surveillance cultures. Okay, now how do you prevent it? So in everything I'm going to say today, hand hygiene is always going to be at the top of the list. And for ventilators, we know increasing the head up to 30 to 45 degrees, and that's related to aspiration. Avoiding a nasogastric tube if possible. I know that is a problem because we like to feed our ICU patients as soon as possible, but we mustn't forget that also there are issues with esophageal sphincter, etc., being open now. Daily oral chlorhexidine mouthwash, and that's because you want to try and decrease the amount of bacterial flora in the mouth, which might then aspirate in things. And daily assessment for the endotracheal tube. So does the patient need to be intubated? Yes or no? Sedation holiday, spontaneous breathing trial, and I'm sure people have seen videos on YouTube of patients that actually go walk around with their ventilators and just getting their lungs going and preventing that atelectasis and getting the cough, etc., etc. Early enteral feeding after ICU admission, and some of that is based on showing that patients that are underweight that go into ICU have a poorer outcome than those patients that are overweight. So hence starting the early enteral feeding. Suctioning of the subglottic secretions, again for the aspiration. Now closed suctioning is another aspect, because if you do an open suctioning, you're removing the patient's vent and then you suction and you lose that initial PEEP. So there's increased risk of aspiration. And by having a closed system, that decreases that risk. And then ensuring your cuff pressure is at a correct level, and then replacing the circuit weekly or obviously when soiled. All right, let's go on to the next part, which is looking at chlorhexidine baths as well as decolonization. And this was a systematic review which was done in 2016, which looked at patients that were given chlorhexidine impregnated washcloths in an ICU versus those patients that did not have impregnated washcloth. So they just had a washcloth with soap and water or a non-chlorhexidine based product. And if you can look over here from this forest plot, and actually it shows that having chlorhexidine impregnated bathing decreased the risk of patients developing bloodstream infections. And in actual fact, what was quite nice to see from this article is that the decrease was noted mostly in patients that have central line-associated bloodstream infections. Okay, now what about decolonization in nursing homes to prevent infection? So this was an article which was released in the NEJM in 2023, and basically it's called the PROTECT trial. And what they did is they used chlorhexidine gluconate with povidone iodine 10%, and they washed their patients daily with chlorhexidine, and the povidone was placed BD to the nasal area and repeated every 5 to 7 days. And they compared that to routine care where patients had daily washing with just normal soap and water. And what you can see over here is that during the intervention period, there was a decrease in the amount of infections in those patients that were decolonized. And the infections in this group were patients that had where they looked for multi-drug resistant organisms such as MRSA and what was the other one? CREs and ESBLs, etc. Okay, now what about looking at antimicrobial stewardship? And now this is also something that is very important. And as you can see over here, it's a multidisciplinary multidisciplinary team approach, and it's important that you have your clinician, your microbiologist, your pharmacist, your nurse, your infectious disease physician, and your infection prevention and control physician. And basically, we do have these antimicrobial stewardships. We have them on our general medicine units at least weekly, and we get a whole group of people to come together and we discuss how to treat patients and when to change antibiotics, etc. Now, if you look over here, what are the core elements of a good antibiotic stewardship program? And that means that having good leadership from the hospital, so ensuring that you've got your CEO, your COO involved, holding physicians and practitioners accountable for what they do. So what I mean by that is, for example, our pharmacists are really great, and if they notice something is a problem on one of the pharmacy blue boards, then they will contact that doctor and ask them to relook at the medication chart and so forth. And having pharmacy expertise, and we're very lucky at Groote Schuur because we have a pharmacist that has specifically been trained in antimicrobial stewardship, and having actions in place. So what we have is we have a standard operating procedure which states how healthcare workers should prescribe antibiotics, and specifically antibiotics for hospital-acquired infections, and then tracking of these infections. So I know our labs are sending the data towards the NICD, and in our IPC unit, we also send off the data to we also send the data to the IPC, the Infection Prevention and Control units, looking at to keep track of where our CREs are, etc. And then educating. Well, this is just making sure that people are aware of what AMS is, etc. And one of the big ways to improve things around the hospital is to look at over-prescribing. So if a patient doesn't need antibiotics, then you need to take that up with the clinician, and also avoiding broad spectrum antibiotics. So that's to do with what the WHO has said with regards to the access, the watch, the reserve antibiotics. And I'll never forget a lecturer of mine from Pretoria who always said to me, don't shoot an ant with a cannon. So don't use ertapenem for a community-acquired pneumonia. Try your ampicillin, or if the patient needs ceftriaxone or cothimoxiclav, then go down that route. Okay, and then avoiding unnecessary combination of therapy. For example, combining ceftriaxone with azithromycin, I don't think is necessary for patients if their CURB-65 score is less than 3. And then wrong antibiotic choice. So this is really important, and I think this is where micro and infectious diseases can really get involved, because if you get a antibiogram and you see that this organism is sensitive to a certain antibiotic, but that antibiotic might not be the best antibiotic for that patient because of the site of infection the patient has. For example, you could say a patient that has got a gram-negative bacteremia, you're not going to use amikacin for that type of patient unless you're going to say it's coming from a urinary source. So it's important to know the source and so forth. And then I can't tell you how many times I've seen blue boards, or rather antimicrobial reports coming back showing that how doses are given incorrectly for patients, not based on estimated glomerular filtration rate, etc. And then doing the wrong dosing interval, and that could also be related to your renal function. Wrong route. So what's really nice is I think there's more and more data coming out to state that oral antibiotics are probably just as good as IV antibiotics, and taking into account, for example, linezolid has excellent oral bioavailability up to 100%. Next part is looking at the duration of antibiotics, so ensuring that we don't give unnecessary antibiotic prophylaxis post the surgical procedure. And as I said, there's going to be a new trial looking at that in the next couple of months to years. And then delaying administration. We all know that. Get the antibiotic in as soon as possible, and ideally, please do your blood cultures before that, so that we can know what the organism is, so that we can treat that organism with the appropriate antibiotic. Okay, and then in summary, I've talked a lot about these different aspects of preventing of hospital-acquired infections, and it's important to know that unfortunately there's no intervention that will fix everything, and in IPC, infection prevention control, everything is multimodal driven. And that's why bundles are very important to try and prevent your clapsies, etc. And one of the biggest things that I think we should really be pushing for is increasing our hand hygiene compliance in our hospitals, and trying to get to that 60 to 70% mark. Please don't get me wrong, if we can hit anything closer to 100%, that would be even more, even better, rather. And then implementation of strategy. So what I mean by that is going for the low-hanging fruits. So, for example, with regards to plabsies, ensuring that we have trolleys, ensuring we have equipment, ensuring we have teaching of clinicians, etc. Those are things that are easy to fix, rather than for example, building up a whole surveillance system using artificial intelligence, which should be done, but it's not very easy. So yeah, that is the end of my slide. I'll take any questions if there are. Thanks.
Thanks, Tari. Really fantastic overview and really important topic that doesn't get enough effort, I think, in local practice. I think it's very, very difficult. I mean, I think the hand hygiene issue is, I agree with you, is probably the central, and most low-hanging fruit to get right for us. Costs nothing almost. And yet it's done atrociously in most of South Africa, and that includes public sector, private sector, across the thing. I don't know. I mean, what would you say if you were health minister? How do you get this process off the ground? I mean, we know it's important. What sort of policy would you do, let's say, in the state sector where there's more limited resources, with trying to get people to change? Really, it's a cultural thing, almost anything. It's a culture within the healthcare system of not making it routinely done. I don't know what your thoughts were in terms of probably the best strategy to sort of kickstart the process in centers where this is done terribly, which is in many centers.
Yeah. No, thanks, Jeremy. Great question. So Like you say, hand hygiene is probably the core component over here to preventing these infections. And one of the things I could say is increasing the amount of alcohol-based hand rubs in and around units. So what I mean by that is ensuring that there's enough alcohol-based hand rub next to patients, because out of sight, out of mind. If it's not next to the bedside, you're less likely to use alcohol-based hand rub. And some of the private hospitals and some public hospitals also have these nice containers that allow you to put the alcohol-based hand rub right next to the patient's cardiac table. They're very expensive though, so it's not something that you're going to be taking to the Minister of Health to try and start. But just having a program by educating healthcare workers on the benefits of doing alcohol-based hand rub, as well as the consequences towards our patients, and getting your IPC teams involved and doing surveillance for hand hygiene compliance. It is quite time consuming, but if you get enough people on board, and having an IPC link person, so that means having a person that in each ward that is that can campaign for good hand hygiene practices and to teach people and to remind people to do hand hygiene. I think that would be of great benefit. It's just basically keep on reminding people to do hand hygiene, and I think with time that will come through. Because also when I was in Switzerland at the Geneva Hospital, I was speaking to my colleagues over there, and I said to them, how do you motivate clinicians to do hand hygiene? And one of them said to me, no, we don't motivate them anymore. It's so entrained in us now that they love it when they get audited. And I looked and I was like, you're crazy. People love it when you audit them. And they're like, yes, they actually come to us after the audit and they say to us, so how did I do? Did I do my hand hygiene correctly? So a lot of it's to do with changing your mindset about hand hygiene and how to do it properly.
Yeah, thank you. A couple of questions some people have asked to do verbally. So there's I've got Molopane on the list. You should be able to unmute. Or maybe it was an accident. Otherwise, Lauren, you had a question?
Hey, Tari, thank you so much. Really awesome presentation. So one of the most common things I find is I'm standing right next to a place where you need contact precautions, and people go in without their apron and their gloves. And I'll stop them, and then they love to say, no, but I'm just going in and I'm not going to touch anything. And so what do you say to them? Because they're like, but if I'm not going to touch anything, why does it matter?
Yeah, thanks, Lauren. It's good to hear from. So yeah, it's one of my favorite comments, right? But Tari, I'm just quickly going in, and I'm like, yes, the bug's going to go on you too.
Yeah,
and
just quickly.
And you know, my argument to them is, guys, do you always know where your body is in position and time? Do you know where your clothing is all the time? Because inevitably, I've watched people say they're not going to touch the patient, but something else on their clothes or their white jacket or their stethoscope touches the patient. And then you're like, but you just touched the patient. No, I didn't touch the patient with my hand. And you're like, but I saw your clothes just touched the patient. So, you know, I really, it's just the mindset change for people, and keep on nailing the hammer on the head, saying to people, please follow the contact precautions. And I think one of the most important things comes from teaching our young clinicians as well as our senior clinicians. If the professor of the ward is practicing good hand hygiene and good contact and airborne precautions, inevitably the people underneath are going to follow suit. But if the professor is just walking in and not doing hand hygiene, then people are going to say, oh, so I mean, my leader is not doing it, why should I do it? So it's a complete mindset change, and unfortunately it does take a lot of work.
Cool, thanks. And then some shorter questions. One was, can you expand on the operation room ventilation? I think that was near the beginning of your slide, one of the factors.
Yeah, thanks. So great question. So that's specifically to help with surgical site infections, and they have some units overseas where the operating table is in the center, and then around the operating table is glass. And what's interesting is it's on the top, the glass is on the top, so covering up until probably halfway up your body. And then there's a lot of ventilation pushing down. So what it does is it's the airflow which goes from top to bottom and then pushes out. So it prevents any airflow coming back from the top. And then that obviously decreases the risk of getting surgical site infections from that way. And then another thing that the operating rooms have is differential positive pressure. So what they do is the pressure within the operating room is different to the area, the pressure in the washing area, which is also different to the pressure in the setup room. So the pressure in the setup room and in the operating theater is going to be where there's going to be the most pressure, so that you get that continuous flow going in a one-way direction. That's what I mean by operating room ventilation. Obviously, that does pose a problem if you've got a patient who's got TB and you're operating with them in that case. Then that makes it a little bit difficult, because then, risk of surgical site infection versus risk to other healthcare workers by pushing TB air out of the unit. So I'd prefer those patients who are under negative pressure in those units. Yeah.
Thanks. And then there's a question asking about a tendency among surgeons in Johannesburg to, as I'm going to quote, sprinkle vancomycin over the surgical field before they close the skin, claiming that there's evidence to support this practice, but can't seem to find it. Is that anything you're aware of? That would be news to me.
Yeah, I must say, that's also news to me. Hey, Jeremy, sprinkling is never a good thing. But in saying that, I know our orthopedic surgeons love putting vancomycin and gentamicin in their cement spaces to try and decrease the risk of prosthetic joint infections at a later stage, and that seems to work quite well. To saying putting vancomycin on the wound, I don't think so. The best way to do it is probably just to make sure that you give your cefazolin at the beginning of just before theater, and then if the patient is obese, increasing the dose. If the patient's been there for more than 8 hours, then give another dose, etc. And the anaesthetists are generally really, really good at doing that. And then obviously knowing the sites. Are you going to just be doing soft tissue, or are you going to be going into the bowel, etc.?
Cool. Tina, you've got a follow-up question?
Yes. Can you hear me?
Yeah, we can hear you.
Okay, great. Sorry, that was my question about the vancomycin. We're having a huge issue just in the private sector in Johannesburg with the orthopods as well as the neurosurgeons, specifically doing spinal surgery, but also, joint replacement. So they don't put it in the cement. They literally do the whole procedure, and then deep into the wounds before they close the skin, they literally sprinkle the vancomycin powder. And the pharmacists, the microbiologists, even the physicians in the hospital have tried to combat this and say to these doctors that what they're doing, is not evidence-based. And they just say that this data was presented at a huge orthopedics, conference, and it's a globally accepted practice, and they're refusing to listen to any of us. Sure. And, that's why I just thought I'd ask and see if you've had, heard this from any, orthopods or neurosurgeons anywhere else in the country, because we just don't know how to tackle them.
Yeah, thanks, Tina. I haven't heard of that, and we just had our orthopedic ID combined meeting 2 weeks ago, and we were discussing infections in these patients, and no one had brought that up, so I'm not aware of it. I guess the thing is with our orthopedic and neurosurgeon colleagues is to say to them, where's the data? I haven't read any data on that. Maybe it is there, but I don't know. I don't know. Sorry. It's interesting though.
I think you're very optimistic in thinking the evidence will be there.
Jeremy, I don't know how many surgeons are on this call.
Hopefully lots. Molopane, who was just struggling to unmute, she was saying her question was about the use of liquid hand soap versus alcohol rub for sanitizers in terms of effectiveness specifically. I know you did kind of cover it, but maybe it's worth reiterating.
Yeah, sure. No, it's such a great question. So I prefer alcohol-based hand rub. And the reason being is the whole rubbing procedure denatures the cell membrane, cell walls of the organisms, and you get that more with alcohol-based hand rub. So what I'm saying is next time you go wash your hands, okay, just think how long you wash your hands for. It's usually what, 5 seconds? 10 seconds. Whereas if you're doing alcohol-based hand rub, you've squirted 3 mils on your hands. You're gonna generally people will continue until their hands are dry because they don't want their hands to be wet. Whereas when you go wash your hands with soap and water, you're gonna quick, and then you're gonna go and then dry them with a paper towel. So I think that's one of the reasons. And then another reason why I prefer alcohol-based hand rub is people develop eczema with let me reword this. Some people may develop eczema with using chlorhexidine, soap and water, whereas with the new alcohol-based hand rubs, they contain emollient inside. So you're killing the bug, but at the same time, you're also protecting your hands that you can still moisturize them so that you don't get that horrible cracked hand feeling after washing your hands or using alcohol-based hand rub on numerous occasions. So I would push for alcohol-based hand rub, but if your hands are soiled, then alcohol-based hand rub is not going to help you. You need to break down that biofilms or et cetera, et cetera.
Cool. It looks like you've got a follow-up question, Molopane. Hopefully you can unmute now.
Yes.
There we are. Perfect. Cool.
Yes. I can hear me now.
Yes, we can. Yeah.
So in settings like operating theater, would you still advocate for alcohol hand rub as in preparation to go into the operation?
That's a great question. So what was it, 5 years ago? The Western Cape had a very bad drought, and there was a standard operating procedure which was sent out to help clinicians actually alcohol-based hand rub instead of washing their hands with soap and water. And that seemed to be taken up quite well. And I know the guys in Geneva are also actually doing that, where they avoid using soap and water, and they use alcohol-based hand rub for the surgical operating theater instead. One thing I might argue against going down the alcohol-based hand rub alone is making sure that your hand is not soiled. That might be a bit difficult in some cases, and I think using soap and water is probably fine in our setting. If you're really struggling on using water, if you don't have enough water, then please do go ahead and use alcohol-based hand rub. And then you've obviously got to do that 15 to 30 seconds is not sufficient. You need to do it properly, as you would for any patient that you're going to do a sterile surgical procedure on, where you're going to wash your hands for a few minutes.
Cool, thanks. We're pretty much out of time, but I'm just going to take one more question. I don't know if you are available, Tari, any further. There's a couple more questions in the chat which you could.
Yeah, sure.
But if you're not, we fully appreciate your time is very valuable. So I'm just going to ask this final question, which is going chronologically about the time cutoff periods for hospital or healthcare associated infections. So is it still sort of 48 hours, or is there a different point at which you would start to consider hospital or healthcare associated infections rather?
Yeah, thanks, Jeremy. So we also use the 48-hour cutoff. If you've been in hospital for more than 48 hours, then you must think of a hospital-acquired infection. If you less than 48 hours, then you must consider a community-acquired infection. Obviously, the lines start blurring when the patient gets sick at 48 hours on the dot. I mean, then what do you say? But most likely it is going. You have to go back into the history of the patient and see, did the patient actually have that fever on presentation, and then it disappeared for the past 24, 48 hours, and now it's back again. So the 48 hours is a nice guideline to assist people with regards to when to consider hospital acquired and when to consider community acquired.
Yeah, thank you. That's really, really fantastic. I mean, this is a huge volume of questions which has come through, which is always a good sign. It really shows how much the topic matters and how much engagement you generated through the talk. So thank you so much. It's a fantastic overview. I mean, to be able to give a bird's eye view of a really difficult field in our is incredibly amazing. So well done. Thank you very much, and thanks for all your time and all the efforts.